Acute respiratory distress syndrome. Introduction. Acute respiratory distress syndrome, also known as respiratory distress syndrome or adult respiratory distress syndrome, in contrast with infant respiratory distress syndrome, is a severe, life-threatening reaction in adult humans to injuries or acute infections to the lung. It is a lung syndrome that causes inflammation of the lung parenchyma, leading to impaired gas exchange with a systemic release of inflammatory mediators, causing inflammation, hypoxemia, and frequently multiple organ failure. This condition has a 90% death rate in untreated patients. With treatment, usually mechanical ventilation in an intensive care unit, the death rate is around 50%, but advances in treatment using prone positions while the patient is mechanically ventilated have reduced the mortality rates to about 25%. A less severe form is called acute lung injury.
Get ready first.
Acute respiratory distress syndrome is an acute injury to the lungs that results in alveolar flooding, atelectasis, and a severe oxygenation defect, but is not due to heart failure. In its early stages, it can cause shortness of breath or dyspnea, increased rate of breathing or tachypnea, and low oxygen saturation or hypoxemia.
So let's go into our progression of Ards here, okay? So with acute respiratory distress syndrome, we have a few things going on here, okay?
Cause. The predisposing factors of acute respiratory distress syndrome are numerous and varied. Sepsis, multiple blood transfusion, pulmonary contusion, aspiration of gastric contents, and drug abuse or overdose are common. Also, burns, pancreatitis, smoke inhalation, pneumonia, and near drowning can cause this condition. Some cases of ARDS are linked to large volumes of fluid used during post-trauma resuscitation. Other causes include shock near drowning and inhalation of irritants or toxic fumes that damage the alveolar epithelium. Treatment. Acute respiratory distress syndrome is usually treated with mechanical ventilation in the intensive care unit. Ventilation is usually delivered through orotracheal intubation or by tracheostomy whenever prolonged ventilation is deemed inevitable. The possibilities of non-invasive ventilation are limited to the very early period of the disease or to prevention in individuals with atypical pneumonias, pulmonary contusion, or major surgery patients who are at risk of developing ARDS. Treatment of the underlying cause is imperative.